today's numbers as usual, and we will look at the system information first. We've done 744,348 PCR tests. System-wide, we've tested 426,708 people. 66,967 have been positive for a total positivity rate of 15.4%. And in Baptist Memphis, we've tested 67,280 people. 6,898 positives have been recorded for a total positivity rate of 9.9%. If we look at hospitalizations today, at Memphis, there are 18 people in acute care non-ICU beds, and there are 16 people in the intensive care unit for a total of 34 right now in the hospital, and 10 of those 16 people are on ventilators at the moment. At Baptist DeSoto, there are 16 people in non-ICU acute care beds. There are 6 people in the ICU for a total of 22, and 3 of those 6 are on the ventilator. So if you look at those numbers, it's sort of plateaued in the 35-ish range in the last few days, which just sort of crept up from, again, a number of about 10 a few weeks ago. And so they've been stable up to the last few days in the 30s, but quite a few ventilated patients. I think one of the real telling things, and one of the things that we notice, is that people are much, much younger. Today, I saw, I guess, 5 people in the ICU before coming over here, and they were all essentially in their 20s, 30s, 40s, and one in the young 50s. And so the numbers are much lower than they were, mostly, of course, because the elderly population has been significantly more vaccinated than the younger population. That, and I think the fact that those other high-risk folks in the elderly age group are sort of subtracted from a lot of the potential victims now, weight seems to be a very, very large risk factor for doing poorly and dying of this infection. It's always been one, but I think when we settle out from some of the elderly population, morbid obesity seems to be the biggest risk factor that we are seeing right now in people doing relatively poorly. That, and of course, being unvaccinated. So happy to answer any questions if anyone has any.
Hey, Dr. Threlkeld, it's Corinne. How are you doing?
I'm good, Corinne. How are you?
I am hanging in there. So can you talk a little bit more about the trends you're seeing in terms of hospitalizations? You mentioned, patients being younger and obesity being factors. Are you noticing any other trends? And, do you really think we're in for a prolonged rise in hospital occupancy related to COVID?
Yeah, I think as we've kind of looked at many times, hospitalization numbers would probably represent the best measurement of how a pandemic is doing in the local sort of environment. And it's risen now and has been somewhat stable. We hope that it won't rise a lot more. I think we've all been reasonably confident that we won't see the sorts of numbers in any way like we saw months before. But certainly the numbers are triple or so in the hospital here. And again, the numbers are driven into the younger population because a lot of the elderly people have been vaccinated. We do see a few cases in the elderly. We do see a few cases in those who have been vaccinated, but it is by far the minority of those cases. And so the age is the biggest factor. I mean, multiple people on the ventilators in their 20s is something that we really didn't see before. And we're not totally clear whether there is some increased virulence factor in that age group, or again, it's just we're seeing a lot higher numbers of infections now, which I think we're really just grappling with how many infections are going on. A third-ish or so of the population is now vaccinated around here, but that's really low, which means there's a large percentage of the population still at risk. We hope that since that population still at risk is a younger population, we'll see a lower percentage of those people requiring hospitalization and ICU stay and suffering death from that. But we certainly are seeing those numbers trend up. I think weight has always been a factor that probably has been underrepresented in when we talk about the infection. But so many folks in the beginning were elderly that I think it masked some of that, because most people don't live to be into their 80s when they're tremendously overweight. It's such a risk factor for premature death that it was probably underrepresented as a risk factor. Now, if you walk up and down the line, nearly all of the people on ventilators are morbidly obese, actually. So it's something I think that has that everybody that takes care of a lot of patients will tell you I think we've all lost weight as a result of that. It's very compelling and concerning when we see it. So I think those are the big trends that we have seen. I mean, obviously the unvaccinated. And just to say about that, yeah, there are breakthrough infections. There's no question about that. But I think that people, unfortunately, on occasions have used that to say, well, the vaccine's not going to work anyway, so I'm not going to bother getting it. I mean, nothing could be farther from the truth. There is apparently some resistance with the Delta variant to vaccine immunity. There was a study I think I mentioned before that came out from Nature that looked at the blood, the serum of people who have been infected, been vaccinated, various states. And they looked at how well their blood in the test tube, the serum, would inhibit virus, how well the antibodies in their blood would attack the virus and inhibit it or neutralize it. And they found that people who had only one of the two vaccines, it was little to no, maybe 10% effective at warding off and neutralizing the Delta virus. That is, as opposed to the Alpha before it, which was much better at that. If you look at people who had had previous infection, it also was significantly lower in folks who had to protect against Delta than against Alpha. And finally, the people who were vaccinated. And here's where the message is very complicated and tedious, and we have to be careful to get it right. There was about a threefold decrease in neutralization of that virus by the blood of people who had been vaccinated, even fully. Now, we have to be careful not to overinterpret that. That does not mean that the vaccine doesn't work, because when you're talking about a 95% effective vaccine, even threefold decrease in efficacy takes you to maybe an 85% effective vaccine. It is important to point out that just because the blood does that doesn't mean that it's going to be a one-for-one correlation with how it really protects in real people and real tests in the real world. But just extrapolating to the extent that we can, even if it were to be true, and it really did correlate nicely, an 85% effective vaccine would have been a fantastic thing. Thank you very much. At the beginning of this, if we'd been told, hey, let's have an 85% vaccine, we would have taken anything north of 50, as you recall. So even with the little bit of resistance that we see with the Delta variant, it's still a very effective vaccine. And that gap narrows when you talk about preventing serious infection, hospitalization, death. So that is, I think, obviously the first job for a vaccine. And even with this resistance, it is almost all unvaccinated people that are hospitalized. It is very painful for us to take care of people in their 20s, 30s, and 40s who might die of this infection totally unnecessarily. And it boggles our minds. We really stand around the ICU shaking our heads, wondering how someone who's now on the breathing machine is not going to get vaccinated. And I've said this before too, but it merits repeating. I think some people are lulled into a false sense of security because our hospitals aren't overrun this time. We hope it stays that way. We anticipate that it will stay that way. But the fact that I have a couple of hour or two less work to do today than I did 6 months ago is not going to help you if you're the one who can't breathe on the ventilator in the ICU. So it should be no reason not to protect yourself. You're no better off unvaccinated today than you were a year ago during some of the higher surges that really put a lot more hospitals under a lot more stress.
Hey, Dr. Threlkeld. This is
Hey, Dominic. How are you?
Pretty good. How are you doing?
Good, thanks.
I just wanted to get your take on the new report that life expectancy has fallen. A group of people that are most affected by this seeing the greatest decline, as well as what led to this.
Yeah, I mean, it is a staggering sort of figure. And I think I've said before that the people on the ground taking care of folks have a lot less patience with the idea that people say this is not that big a deal and it's just like the flu. No, it's not. It's killed well over 600,000 people in the United States. It has taken the life expectancy of Americans down a year and a half. That is the highest value since World War II in 1943. And that in 1943 was the only other one that compares, dating back to the 1918 influenza pandemic, was a shocker to the life expectancy curve and dropped it significantly. But when you drop the life expectancy curve, you have suffered a tragic situation. No one should be able to make the argument that this is not a catastrophe on local, regional, national, and world levels. And so when you look at that, it surpasses easily the Vietnam era. And it's the sort of thing that we just can't imagine that people wouldn't want to protect themselves from that and end this process. I think you may have mentioned there, and certainly in the articles about this and in the data that we saw, it wasn't just COVID-19. COVID-19 accounted for the majority of that decrease in life expectancy, but there were some other things such as unintentional deaths, like overdoses, and drug overdoses went up dramatically as well from their baseline. And so that really speaks to just the tragedy of the entire situation, of all of the lost businesses and the lockdowns and people who really couldn't make it work in their lives with the problems that really came from COVID-19. So it is truly a historic tragedy. And as I say, I frequently quote my mom, who's 91, and she lived through World War II and everything since, and says there's nothing that comes close in terms of the effect on life and kind of the tragic nature of this. So we hope we don't ever in our lifetimes see something that drops the lifespan of Americans a year and a half. It further than that increased the discrepancy in life expectancy between Caucasians and people of color, for example. There was already a gap. This widened the gap. That's not a surprise, of course, because it hit populations of color, socioeconomically stressed populations in a great deal harder way. And we've talked about that over the months, of course. People who live in multi-generational homes and in more crowded situations, people who were essential workers and really were forced to go to work and didn't have the luxury of being able to just carry on work from home via Zoom calls and the like. So that's another tragic element of this. And it's going to take us a while to dig out from this in so many ways. But again, I hope it's a message to those who really have not understood so far how severe the impact has been of this. I mean, it's a tragedy literally of historic proportion.
I had one or two reader questions, again, that I wanted to put to you. The first is from a woman. She got her second shot back in May, but she occasionally has to take prednisone for rheumatoid arthritis flare-ups. She was concerned that might mess with her antibody levels. Is that something she should be worried about?
Yeah, these are very difficult questions. And so what we try to do in these situations is extrapolate from things that we do know to those sorts of situations. It's probably the worst thing is to be on that steroid dose or being immunosuppressed when you take the vaccine and you have a hard time ever generating the antibody immunity in the first place. But certainly people who are immunosuppressed from various types, taking prednisone for that, chemotherapy, particularly with blood malignancies like leukemia and lymphoma, to a lesser extent, probably chemotherapy for solid organ tumors, breast cancer, lung cancer, colon cancer, and certainly organ transplants are all people that you would expect a lesser response to the vaccine for protection. Now, what do we do about that? That is the much harder question. Certainly, there's been a lot of discussion about those folks needing a third vaccine as sort of a booster in the true sense of what a booster is. And interestingly, the vaccine regulatory commissions are looking at that question right now. We don't have the data yet to know. And I'll take a step back further. We don't even have the data to know what antibody levels even mean. Many of us check antibody levels in targeted circumstances, but you can't let anyone tell you that we really know what that means, because we don't. There are studies that have been designed and have begun in England that try to look at, they actually re-challenge people with COVID-19 doses to see what antibody levels protect to what degree. Now, there are many people who don't like those tests and would declare them to be unethical. But until something like that comes out, we're not going to really know whether an antibody level of 50 to a spike protein means that you can't be reinfected or not. And it may be that it takes 70 or 20. So we don't even know what a positive test and a negative test would be in terms of the practical nature of that protection. So antibody levels to me, and a lot of people will come to me and their doctors checked an antibody level. And the first thing you have to do is to make sure that you're checking the correct antibody level. We've mentioned this before. There are two basic types. One is the total antibody. And what that really means is it's the nucleocapsid protein antibody. That represents natural infection. The spike protein antibody is the test you need to get if you're trying to see if your vaccine has had any effect, because the vaccine doesn't have any nucleocapsid protein in it, so your antibody level would be 0 if you tested the wrong antibody. So you have to check a spike protein antibody, which would be positive regardless of whether you have the vaccine or the real infection. If you have no antibody when you check for a spike protein antibody, then that makes me very worried that you have no protection. If you have greater than 250, I think many of us would think, well, that's pretty good indication you had a nice response to the vaccine with all that entails. Everywhere in between, it's really hard to know. And again, we all try to make it up best we can and to try to interpret those things. But those values in between can be very, very difficult to really interpret. So I think what to do when you're immunosuppressed, it won't at all surprise me if we end up saying, hey, a third vaccine will be good for those people. But the only real study we have on that is something we've mentioned before. It was a Hopkins study where they took solid organ transplant people, and a lot of them had no vaccine antibody response whatsoever. They took those people, revaccinated, and about a third of them developed low-level antibodies. Again, whatever that means. And of the ones that developed low antibodies, they revaccinated them, and all of them got an increase. Now, emphasize all 6 of them, not 10,000 of them. So it's really hard to make any sweeping recommendations based on that. But don't be surprised if the regulatory bodies come out and say a third vaccine is appropriate in those people, but we just don't have full data to be able to recommend that. And if we extend that to non-immunosuppressed people, we don't know yet whether a booster vaccine is helpful in those folks either. I would emphasize that so far, the numbers look really good for people with normal immune systems who've been vaccinated out 6 and maybe even 9 months out. So that's been better than we had feared or anticipated. And the idea that we need a vaccine booster every year, which has kind of been put out by vaccine companies, and I might put that out too if I were a vaccine company, but we just don't have enough data to suggest that that part is necessary. But back to that reader, and again, to generalize, not so much for that person, but for anyone who is immunosuppressed, I think it makes very good sense for you to be more careful than the average person, more likely to wear a mask, more likely to avoid indoor poor ventilation areas, because you're probably going to be at increased risk. We certainly have seen some people get substantial disease who were immunosuppressed who had been vaccinated.
And one other reader question. This is from someone who said she had the Moderna vaccine. And she said there hasn't really been as much news as there has been about Pfizer in terms of how well it protects against variants and if booster shots will be needed. So she's wondering if she can, since they're both mRNA vaccines, if that information, that she's getting about Pfizer applies to Moderna, or if she shouldn't really be paying attention to that news about Pfizer.
Yeah, I think from what we've seen so far, RNA vaccines have driven the same road together. There's been very little indication that one was substantially better or worse than another one. It's funny that these things have shifted over time. When I first got my vaccine, I got a Pfizer vaccine because I walked around until somebody provided me with a needle and a vaccine, and I took whatever I could get. And Pfizer happened to be the first one I got. If I had had 2 hands held out to me with 2 vaccines, I might well have chosen the Moderna then in a 51-49 sort of struggle, because there were just a little more interesting and substantial data at that point for Moderna. That's probably flip-flopped to be 51 Pfizer, 49 Moderna, simply because of the data that we've seen. But we don't have any indication that you should be worried at all if Pfizer happens to be first to the bank with a test that says that they do well and overcome some problem. We don't have a lot of indication that you should have anything to worry about. Both have tracked very nicely together, and they're both spectacular against all of the variants that we've seen now. And I mentioned, and I want to beat this hard, in that there's less efficacy against the Delta and some of the new variants than there was before, but it's still great. The lesson in it being a little more resistance is that we've taken a little trip down a long road toward resistance. And we don't want to continue traveling that path. But at the place we are now, we're perfectly fine and the vaccines are great. We don't want anyone to say, well, I give up. I'm just not going to take the vaccine because it's not going to work anyway. It is absolutely going to work. And this came through in several questions on the feed last time. And I'll try to answer 1 or 2 of those, time permitting. But no, that people would ask, well, what does it matter if the vaccine is not going to work anyway? It still does work. It works amazingly well, and particularly beyond that, even well at preventing someone from getting sick and dying. And if that's not the first thing a vaccine is supposed to do for us, I don't know what is. Any other questions? think there's a little time for some other kind of reader questions. One, Lee Butler asked, or actually mentioned, I guess, that ivermectin was a good preventive against COVID. A few doctors will prescribe it in lieu of not getting the vaccine. I would strongly urge against the policy of using ivermectin rather than a vaccine. When you compare the two things, there are a couple of small, really poor quality studies. And when I say poor quality, they just aren't well controlled. They're not great studies. They easily could be false or biased in one direction or another that gave some indication that ivermectin could be helpful. As I say, these studies are really, really weak. And to compare that to the amazingly impressive double-blinded, placebo-controlled studies of the vaccine is just, they're not even in the same league. And so anyone that would put any faith in ivermectin, and there are some larger, more controlled trials to come out, and I'll believe whatever the data tell me in those, but as of yet, it's extremely weak. And there are certain problems. I give ivermectin. I'm an infectious disease person. We give it for certain parasitic infections, strongyloides and the like. So we give it as a preventative before organ transplants occasionally. There are the reasons that we use it, but there just is no reason to even think that it would be effective against COVID-19 as an anti-parasitic. And in fact, nothing has really borne that out. But when you compare that to the vaccinations that are just amazingly impressive in the data and far beyond what we would have anticipated, if you're at all interested in taking ivermectin, you should have been beating the door down to get the vaccine, just based on the quality of information and data that those things show. One reader says, again, so tell me why you take the vaccine and you still get COVID, because the vaccine is not perfect, of course, and people can get mild cases of COVID, but very few, if any, really get sick from it when they're fully vaccinated. So you gain the advantage of not getting as sick, not being able to put out as much virus to give it to other people. I would emphasize the point one more time that the people I've seen who've gotten sick, who have been fully vaccinated, tend to have been people who were in situations that were avoidable. That is to say, they were at the ground floor of sort of a super spreading event. They may have been in a gathering in the families or a church, what I've seen, where maybe 2 or 3 members of their family all got sick, which tells you that when multiple vaccinated people get sick, there's a lot of virus that's floating around there. And they may just have been sitting next to the person that was a high viral load person, unvaccinated, and spreading it to a lot of people. So to me, and as far as my behavior goes, it still makes sense, even if you're vaccinated, to avoid the highest risk sort of circumstances. And I'll tie in a question I know that's coming later. What about outdoor sporting events like the Liberty Bowl? And to tie that in, if I'm in an indoor situation with poor ventilation and I'm sardined in with people that might be unvaccinated, I wear a mask in that situation, because those are the situations that I've seen people just have their immunity overcome by a large inoculum exposed to a lot of virus. And as I've said before, that's kind of what happened, I think, to a lot of young, relatively healthy healthcare workers in New York. Many of them died at higher rates than we see now, simply because I think they just got so much virus thrown at them as an inoculum, it overcame even their young, healthy kind of immune systems. When you look at packed football games at the Liberty Bowl, it gets much more complicated. As I like to say, anyone who's been to a football game at the Liberty Bowl in December knows that there is no better ventilation out there in the world than that spot. Windy, high sort of airflow. So it's a very, very low risk when we really look at situations. So if you're vaccinated in that situation, I think the odds of you having a problem there would be extremely, extremely low. If you're unvaccinated and not protected, that's a lot harder decision. And if you're really packed in with a lot of people that you don't know are already vaccinated around you, then it probably is more reasonable to consider wearing a mask, though I expect not to see many people doing that when we look forward to see what happens there. And here's an interesting point too, and a lot of these I'm kind of dispelling rumors here because they're important. One reader asked that the spike protein in the vaccine have to settle somewhere in the body. Research before you take it. This seemed to be a point against the vaccine. And I think the misperception there is that the spike protein from a vaccine settles anywhere. There's very low production of this relative to what you would get with the actual infection, thousands of times less, probably. And the RNA that causes that protein to be temporarily produced is very brief. The body makes changes very quickly, fight or flight stuff, other things based on messenger RNA being cranked out and quickly degraded. Messenger RNA is a flimsy piece of material that does not last long at all in the body. It's why it took us long enough to get this technology available to us, because in order to shepherd messenger RNA, this really delicate little molecule into the cells, it took a lot of time to use the nanoparticle technology to get it there safely and shuttle it in. It's a very delicate piece of material that gets broken down very quickly in the body and does not last very long at all. Melinda Hawkins asked, how can a person tell if they actually had COVID and not a cold? I think this is such an important question because you can't, particularly if you're a vaccinated individual and even unvaccinated to a degree. You may have very few to no symptoms by having COVID. If you've been vaccinated, you're very unlikely to get sick at all. But we have problems convincing people still to be tested in the community when they had minor respiratory symptoms. It probably still makes sense, particularly if you're around someone at risk or immunosuppressed or someone who's unvaccinated. That may be your COVID case. And so particularly here in the healthcare facilities, we encourage anyone with so much as the sniffles to go out and be tested, because that may be a way that you would transmit to others. Now, if you're vaccinated, you're probably not likely to put out much virus to really spray at someone. But still, if you're around someone who's at risk for that, then it makes sense, at least at this point, as we're starting schools and need to keep up our careful monitoring, it probably makes sense to be a little more aggressive at testing people and looking for contacts, even as it seems that we're kind of relaxing some of the mitigation behaviors, maybe whether we should completely do that really or not. Once more, I'll tackle this. What are the long-term effects of vaccines? And I'm going to dovetail that with a particular several emails that I had, one from a previous patient named Sarah. Long-term effects from vaccines are not really things. They really don't happen. Things don't pick up 6 months later and cause problems after a vaccine. That you can have short-term reactions to them, to be sure, but those others are really very uncommon. Unlike the persisting, nagging, sometimes even serious long COVID side effects that we're seeing in large percentages of people who've had COVID. That can include children. So it is really a problem. And I want to tackle specifically at this lady's request, the idea of fertility. I've talked about this before, but it is becoming a very large percentage of the people that say, the young people who don't want to get the vaccine because of fertility issues. And just to deal with that directly, it is nothing short of an internet ruse or prank that sort of popped up because a scientist looked at some of the genetic sequence of spike protein, and they said, wow, there's a little, and I emphasize a little, homology or sequence similarity between that and a protein in the human placenta. And so could it be that a spike protein vaccine could engender an antibody that would mistakenly attack the human placenta? So my response to that would be this. Not only is there zero evidence that that has ever happened, many people have gotten pregnant during the vaccine trials that they didn't realize was happening, or since the vaccine, and it's never been shown to have any effect on pregnancy, fertility, et cetera. Second, the whole idea is ridiculous on its own terms, because if a vaccine caused those antibodies that could attack the placenta by mistake, what do you think will happen when thousands of times more spike protein is produced by the infection itself? So you'd be protecting from something that would be much more likely to keep that sort of thing from happening if it could happen, for which there is no evidence. We would have seen, if that were the case, a historic decline in fertility worldwide, and we've seen nothing of the sort. So the fertility issue is completely ridiculous based on there's no data for it in the first place, and even if there were, infection would be worse than any sort of vaccine at doing it. And so we've seen none of that. So I think that's an important thing for people to understand, because it is becoming all too commonly a reason that people are not being vaccinated. And it just really is an unfortunate situation. I think I'll stop there in the interest of time. Any other questions I can answer? Okay, thanks. Have a great weekend.